So let me summarize what I've been trying to convey to you. The goal for us as an ophthalmologist is to phenotype the patient as precisely as possible and facilitate phenotype-driven genetic analysis and genetic confirmation. And that here are some of the phenotypes that we should be able to discern. And here are some of the genes that can be responsible for some of those phenotypes. You see how there's overlap. This is our goal, molecular diagnosis for every patient. Why? It allows genetic counseling. It identifies if there's a risk for systemic disease. It identifies if the patient is eligible for gene therapy trials, and it also identifies if a patient is eligible for gene therapy. Sometimes also it uncovers that we're actually not dealing with an inherited retinal disease and it's actually something else. The other important goal for the ophthalmologist is to make sure the patient has optimal refraction. I can't overemphasize this. I see many patients who are told nothing can be done, but they benefit tremendously from optical correction. So please don't forget this. In the remaining now 5 or 10 minutes I have, we'll go through some practical examples of what I've spoken about. Here's a boy who, since birth, has had poor vision. He's photophobic. He can't go outside. It's just can't open his eyes. His eye exam looks completely normal, except that he's hyperopic. Situation like this, when you have severe photophobia, decreased vision, is really suggesting a cone dysfunction. This is where you get an ERG. We do an ERG. There's no cone readings, but the rod readings are normal. This patient has classic achromatopsia, one of the classic phenotypes in inherited retinal disease. Gene therapy trials are underway for achromatopsia. There's no gene therapy at this time, but there is something we can do for this patient, and it's very, very important. We can give him special filters, and I've seen these filters change these patients, the lives of these patients very significantly, from not being able to go outside in normal sunlight to being able to go outside and functioning outside. This is a very important intervention. Again, optical intervention is very important, even if we don't have a treatment for the underlying retinal disorder. Filter lenses not only can help patients with cone dysfunction syndromes, also some patients with rod-dominated problems benefit from different filters that we can provide them. Here's an adult referred for genetic testing. He's a 44-year-old male. He was diagnosed with pattern dystrophy. Pattern dystrophy is a type of maculopathy. He's just referred for genetic testing. His vision is actually good, but some patients with pattern dystrophy have good visual acuity. And here you can see this modeling in the central macula. And you can see here on the OCT as well. His ERG was normal. But before we go on to genetic testing, there is one critical thing that we have to highlight here. We have to highlight his medication history. And he's using this drug, PPS, for cystitis. And this is PPS-associated maculopathy. This is one of the drugs that can lead to retinal dystrophy. Again, all of these patients, particularly adults, really get a good history, especially with these newer anti-cancer drugs. We have a significant number of patients that have toxicity-related retinopathy that are mistaken as inherited retinal disease. Here's a 15-year-old girl with long-standing poor vision referred for IRD genetic testing, poor history from family. You can see she has pigmentary retinopathy for sure, and the discs look a bit pale, the vessels may be a little bit thin. The ERG is non-recordable. Okay, this picture looks like a good, does look like an example of inherited retinal disease. I mean, it's compatible with it, but what's missing here? What's missing is the history, and we're not going to diagnose inherited retinal disease unless we have a good history. And when we go back to the old records, we find the records of this patient. When she was 6 years old, she had an episode of bilateral posterior uveitis with vasculitis. And this is the sequela of that. It's not a gene mutation. The retina has only a certain number of ways to respond to stress and death of photoreceptors. And the end stage looks very similar in inherited retinal disease, inflammation, medicine toxicity. So we don't jump to the diagnosis of IRD unless we have good evidence that that's what we're dealing with. And again, it all starts with good history. That's critical. I can't make any diagnosis in any of these patients just by looking at the picture. We have to have good history. Here's a 7-year-old boy with low vision and nystagmus. He was diagnosed as inherited retinal disease, but he had whole exome sequencing, which was negative, referred for ERG to better phenotype the patient. And okay, that's interesting. Sure, many patients with low vision and nystagmus who are otherwise healthy do have inherited retinal disease. But phenotype is very important. And when we look at this patient carefully, let's zoom in. This patient actually has the retina looks pretty good, actually. Again, having a normal looking retina doesn't exclude retinal dystrophy. But when we look closely, he's got optic nerve hypoplasia. Can you see the inner arrow is pointing to the end of the optic nerve, and the outer arrow is showing a peripapillary halo around the optic nerve that could be mistaken as the outer rim of the optic nerve, but it's not. It's a peripapillary halo. This child has optic nerve hypoplasia. So again, phenotype, phenotype, phenotype. Don't jump to diagnoses just because inherited retinal disease is a little bit more common. Here's a teenager referred for recent reduced vision. Outer retinal loss. He has rod cone dystrophy confirmed by ERG. No significant refractive error. He does have pigmentary retinopathy. So this is a pigmentary retinopathy. But we need to take the whole phenotype. We need to look at everything. And this child, even though he wasn't complaining about it, he has ptosis. And even though he wasn't complaining about it, he has limited extraocular muscles movement. He's got a mitochondrial disorder. Why is this so important to pick up? These children are at risk for heart block, or children and young adults, and have to be seen by a cardiologist immediately. So again, don't just look at the eye, don't just look at the retina, that is, look at the eye, look at everything, think about these things. Always worry about children, the possibility of a systemic disease. Here's a teenager referred for reduced vision since early childhood. He actually came in asking for treatment. The child definitely has a retinal dystrophy, has myopia, but has these complaints actually that go with a certain condition. It's not specific for the condition, but it's suggestive of it. Present since infancy, used to stare at lights the first year of life, and then stopped. Vision seemed to improve in early childhood, particularly poor night vision. This is leading to suspicion of his particular type of retinal dystrophy, although it's not specific. Here it is, it's a dystrophic retina, but what's striking is on the shortwave autofluorescence, there's no background autofluorescence. Normally there's zero on this patient. Here is an image of the autofluorescence again, because the machine didn't detect autofluorescence. It turned up the gain, made the discs white. The discs are supposed to be black. If we go to the unadulterated image, this is what it is. It's not just a black square. There's no autofluorescence coming here. This is suspicious for RPE65 related retinal dystrophy, and that's indeed what this child had. This is the form of retinal dystrophy for which we have gene therapy. We want to pick up these patients as early as possible because we can intervene. And this lack of autofluorescence signal on the shortwave autofluorescence is very characteristic. It's not the only thing that can cause that, but it's one of the few things that can. Gene therapy we have now and don't have time to talk about, but it is available. Here's a young adult referred for progressive visual loss since childhood. He's a 20-year-old male, generalized delay since early childhood. His retina is dystrophic, no significant refractive error, rod cone dystrophy by exam and history. But here, alarm bells go off. I'm always concerned when a patient has delay, retinal dystrophy in the context of delay or weakness. Just to get to the bottom of it, we have to investigate this child. And when we do, we find out that he has A beta lipoproteinemia, also known as Bassen-Corbin syndrome. This is why he's weak. This is why he's not eating well. The tragedy here is, had this been diagnosed as a child and he were treated with vitamin A supplements, vitamin A and E supplements, neurodegeneration and retinal dystrophy could have been prevented. Again, this is why all children, we really have to be on alert, and we really want to understand the molecular diagnosis, because among the patients we see with inherited retinal disease, some of them are treatable, and the treatments are most effective when we get them early. Always think about hypovitaminosis A in any patient with suspected of inherited retinal disease. It's not always from gene mutation. Basen-Corbin disease is a gene mutation of malabsorption syndrome, but we see it after bariatric surgery sometimes. So think about that in your bariatric surgery patients who come in with retinal dystrophy. And even in children with autism, sometimes they have very bizarre diets, and it results in vitamin A deficiency so severe that it causes retinopathy. There are some other inherited retinal diseases that are treatable listed here. Sometimes IRDs are not recognized. I think I will just close with this patient here because of time. And it's a 6-year-old girl referred for strabismus surgery. She wasn't actually referred because of IRD. She was referred for strabismus surgery, but she didn't correct to 20/20. The fundus looks myopic. She has slight nystagmus, was seen by a retina specialist and told that the retina is normal. Why did the mother see a retina specialist? Because the child has poor night vision. However, the key here again is that just because the retina looks normal doesn't mean that there's no retinal dystrophy. And this is one of the most underdiagnosed conditions that I see. A child with high myopia, vision doesn't get quite to 20/20, multimodal imaging is normal. That doesn't rule out retinal dystrophy. And this is a situation, if there's a complaint of poor night vision or the vision doesn't correct to 20/20, you have to get an electro ERG to understand what's going on. And when we do an ERG on this patient, again, multimodal imaging normal, there's no scotopic function, no night vision, an electronegative combined response, normal cone function, pathognomonic for congenital stationary night blindness. The only way to diagnose congenital stationary night blindness is by an ERG. So if we don't do an ERG, we can't diagnose them. Again, the multimodal imaging is normal. If a patient is complaining of poor night vision, or a patient doesn't correct to 20/20 and you don't have a good reason for it, consider an ERG. Some of these patients have inherited retinal disease. With that, I will end. I appreciate the opportunity to speak in this conference, and I hope that the rest of the conference goes well. Thank you very much.